Welcome, everybody. My name is Margaret Harris Brockman, and I'm the Senior Program Manager at the National Collaborating Center for Infectious Diseases, or NCCID. Thank you for joining us today at our webinar, Interpreting and Communicating the Signal from Wastewater-based Surveillance, hosted by NCCID with partnership with the Canadian Water Network. I'd like to begin by acknowledging that NCCID is located at the University of Manitoba on the original lands of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and the homeland of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land, and we recognize that this and other treaties have been implemented as part of a process of colonization intended to benefit some while harming others. We are committed to working with our partners towards reconciliation. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy, and is supporting the agency with knowledge translation in many areas. NCCID formed a strategic partnership with the Canadian Water Network to implement a demonstration project on wastewater-based surveillance starting in February of this year and going at least until March 2024, if not longer, supported by the Public Health Agency of Canada and Indigenous Services Canada. The aim of the project is to support the learning needs of public health practitioners working with wastewater surveillance data. The heart of our program is a group of local public health personnel from across the country who are working with wastewater-based surveillance data. They form our strategic sharing group, a group that meets virtually every month, hearing from experts and peers on interpretation and communication of surveillance data. Today, we have the good fortune of having a presentation by Dr. Amy Kirby from the U.S. Centers of Disease Control and Prevention, followed by a discussion between Dr. Kirby and the members of our program's strategic sharing group. The objective of the project is to build knowledge around wastewater-based surveillance for infectious diseases and perhaps other pathogens and subjects of interest, and to better inform public health for policy and practice. We're delighted that our moderator for today's webinar is Dr. Wendy Ponce, a member of our program's expert advisory group. Dr. Ponce, over to you.
Thanks, Margaret. So I'm a professor from Conestoga College in the Bachelor of Environmental Public Health program. And as Margaret said, I also have the honor of being a member of the expert advisory group on the wastewater-based surveillance group. I'm pleased to be introducing our speaker today, but before we begin, I wanted to mention a couple housekeeping items. We are running this webinar through Zoom, and if you have any technical problems, please email the NCCID, and I saw that the email address has been put into the chat. The question and answer session today will be focusing only on today's topic, interpretation and communication of wastewater-based surveillance data. The session will be taking place using the Q&A tab, so you can add your questions as they come up. You can also like other people's questions to push them up in priority. We'll try to answer as many questions as possible, but we may not be able to get to all of them. The host will use the chat tab for extra communication to any participants, so please keep an eye on that tab as well. The recording for this session will be available shortly after the webinar at nccid.ca. Without further ado, I'd like to welcome Dr. Amy Kirby. Dr. Kirby is an environmental microbiologist in the Rapid Response Research and Surveillance branch and the program lead for the National Wastewater Surveillance System at the Centers for Disease Control and Prevention. She is a Bachelor of Science in Agriculture from the University of Georgia, a PhD in microbiology from the University of Buffalo, and a Master's of Public Health and Epidemiology from Emory University. At the CDC, Dr. Kirby is interested in leveraging environmental microbiology methods to measure pathogens, antibiotic resistance genes, and other health indicators in natural and man-made water and wastewater systems. So I'd like to hand it over to Dr. Kirby now.
Great, thank you. It is so nice to be here. I will turn my camera on for just a minute so that hopefully you can see me and put a face with the name. But otherwise, I'm going to turn it off for bandwidth because I'm on my cell. So what I want to do today is really divide this talk into 3 sessions. So I'm going to give you an overview of the National Wastewater Surveillance System and what we have established for COVID and how we've grown that program over the past 3 years. And in the middle of the talk, we're really going to dive into how we visualize our data for different uses and how our public health implementers are using those different visualizations to be able to take action. So we'll spend most of our time talking about data visualization. And then at the end, I want to look forward a little bit and give you a view of where news is going in the next few years. Next slide, please. So wastewater surveillance is not new. It has been around since the mid 1900s, being used for polio surveillance quite effectively. Although wastewater surveillance, as we know it in the COVID era, is actually quite different. So instead of just looking for areas where a certain pathogen is circulating, we're really looking to understand trends. So are cases increasing in a community? Are they decreasing? How are they spreading across and between communities? So it's a much more quantitative way to track trends in infections across communities. And when we built the news system, so in WSS, we call it news, when we built that, we really wanted to build a surveillance platform that would be useful beyond COVID. So even from those early days, we were looking for something that would be useful for multiple public health challenges. So looking at this, obviously pandemic preparedness, it was built for a pandemic. It would be useful, most likely, to have in the event of another pandemic. We're also thinking that this could have great utility for emergency response. So for things like large flooding events or natural disasters, we often get worried in the wake of those events of outbreaks of infectious disease, but there's limited ways that we can get information on that. But if you have wastewater surveillance, you could think about doing a local or regional activation of that wastewater surveillance system for the outbreaks that are of concern. We also think wastewater surveillance could be really helpful for emerging infections. So often when we have a new infection that we're interested in or that we want to get more information on, what we first get is information on the most severe cases, and we don't understand what's going on in the community. Wastewater surveillance gives us the opportunity to look at that community level transmission, even of these emerging infections. And then there's also a potential application for bioterrorism. So should we be concerned about a potential incident, or if we know there's been a release, you could potentially use wastewater surveillance to track dissemination of that agent. Next slide. So this is really looking at that surveillance triangle that I was just alluding to. So what we, of course, want to avoid are those worst case scenarios for any infection. We don't want people hospitalized with severe disease. We don't want deaths. But in order to control and prevent those early or those most severe outcomes, we really need to be looking at the less severe outcomes. So how do we control, people that are reporting cases and people that are reporting to their doctor for, mild infections? And what about those infections in the community that may not have any symptoms at all? And generally, our clinical surveillance is at the top of this surveillance triangle. So we have good information on deaths, pretty good information on hospitalizations. We're getting better at ambulatory care. But until wastewater surveillance, we really didn't have anything that gave us consistent routine data on community level infection trends. And wastewater surveillance gives us that data. So first, as you see here in this bullet, it serves as an efficient pooled sample of community infection levels. So essentially, we're using wastewater as a pooled community stool sample or urine sample, if that's how the pathogen is excreted. And we can look at wastewater over time and understand if trends in cases in that community are going up or down. Some of the real power here is in this bullet and the next one. So wastewater surveillance captures asymptomatic infections. So for COVID and most of the other infections that we've looked into, people that have symptoms excrete virus or pathogens at virtually the same level as people that don't have symptoms. And so all of them show up in wastewater surveillance the same way, unlike all of these other clinical surveillance systems where we're really only seeing mostly symptomatic people. And then probably most importantly, it's independent of healthcare seeking behavior and testing access. So the public doesn't have to do anything. They don't have to change their behavior at all. They don't have to seek medical care. They don't have to get tested. Of course, with COVID, there's a big change in testing at a doctor's office versus testing at home. It doesn't matter. As long as they continue using a toilet that's connected to a sewer system, we can get really good, robust data on community trends through wastewater surveillance, even as all of those behaviors are changing. And then one more bullet. And then the last thing is this has turned out to be really fast. So we've seen over the course of the pandemic that we can detect trends in wastewater surveillance on average 4 to 6 days before we see those same trends reflected in case data. So 4 to 6 days doesn't sound like a lot, but in COVID world, that is a lot of time to take action and make sure that the community has all of the resources they need to prepare for those cases that we'll be reporting to their doctor and to the hospital in the next week or two. Next slide. So the new system was established almost exactly 3 years ago in September of 2020 and has grown quite rapidly since then. So the map on the left shows you all of the states and territories that are supported with CDC funds for wastewater surveillance. So almost the entire country. We also fund some of our large cities directly and provide funding to 2 of our territories. We have also established 4 new centers of excellence, and the goal for those centers is really to drive forward the practice of wastewater surveillance for public health. And they are based at health departments and have partnerships both with academics and with utilities to recognize that this is really a multidisciplinary approach to public health surveillance. And then the map on the right is showing the growth in the number of sites that we have reporting data to CDC over the past 3 years. So we have over 1,600 sites now that are reporting data twice a week to CDC, and that's in all 50 states, 3 territories, and 12 of our tribal communities. So in addition to the directly funded states in the map on the left, we also have a large commercial testing contract that allows us to fill in the gaps where we don't have support through our state-led system. And collectively, all of those sites represent over 144 million people. So that's over 40% of the US population that we're getting data on twice a week. Next slide. And as I've said, this really is a very multidisciplinary approach to public health surveillance. And so to support the rapid development of this new approach to public health, we've established these 3 communities of practice for each of our partner groups. So there's one for health departments that's hosted by CDC. So health departments are really our coordinating body. So they're the ones that are making decisions about what utilities should be participating, how to distribute their resources and sort of testing capacity across their state. And of course, they're the ones that are looking at the data and making decisions about how to take action on that. And then laboratories. So we do not have a single central laboratory. We chose to do this through a distributed laboratory approach, which is pretty common with CDC. So it's a combination of state public health labs, academic laboratories that are contracted to state health departments, and commercial testing labs. So we have a community of practice for our laboratories. They're very focused, of course, on methods development, piloting workflows, and of course, biosafety concerns as well, and quality control. And then finally, we have a community of practice for our utility partners. And that's really to help them understand how this data is used, think about how their operational decisions will impact wastewater data so that they can be partners in this and help us understand when the data may not be as reliable as it could be because something changed in the operation of the wastewater system itself. And then CDC, along with our partners, the Association of Public Health Laboratories and the Water Environment Federation, coordinate across these communities of practice to make sure that they're all getting similar information and stay connected that way. Next slide. Okay, so that's sort of a very high level background of news. Now I want to dive into the data and how we've been visualizing that. Next slide. So we really want to talk about interpretation and action. So one of the things that's become quite clear with COVID and with wastewater surveillance in particular is that there is such a thing as too much data. So we definitely want to have all of the data that we can, but sometimes you really want to be able to crystallize that down to a single or a handful of take-home points that really feed into the action. You don't need to get into all of the depths of the data all the time. And so it's been a work in progress to find out where that line is for wastewater data, and it's changing. Next slide. So the real heart of our system, so one of the challenges is that we have multiple audiences. So this is an overview of how what the new system works. So communities produce the wastewater that then flows to the wastewater treatment plants where they collect the sample. As you may have experienced as you're doing this, wastewater utilities feel a lot of ownership over their wastewater, and they want to know what's in it, even if they're not going to be acting on it. That then goes to the laboratories. Of course, they're the ones doing the tests, so they have a lot of interest in the data as well. That goes to state, tribal, local, and territorial health departments, who are, of course, going to be acting on it. And then CDC as the sort of aggregator of all the data. And then I think if you hit, you advance one more time, one more. We also have external partners. So these are the core news partners that are actually part of producing the data, but then we're also seeing that state health officials are using this data. So the governor's office may be looking at this data, or the mayor's office may be looking at this. And of course, we also have academics that are interested in doing research and continuing to develop wastewater surveillance or understand how it can help us to interpret other types of data. And so we want to be able to support them as well. And all of these different users have different levels of technical expertise and different interests. And so we need to try and make sure that there is a data source for all of them that is appropriate. And it's not going to be one data source, it's going to be multiple. So we'll go through some of the options that we have developed. Next slide. So the real heart of our data system is our Decipher dashboard. So Decipher is an internal system that was developed for CDC. It stands for Data Collation and Interpretation for Public Health Event Response. So it's basically our outbreak data hub, and it became our data hub for all things COVID. And within that, we have a wastewater surveillance module. And this is what our public health users will use. So the folks that are the most technically savvy about wastewater data, this is where we want them to go to get their information. And so when you go here, you're going to see this overview of the whole country. You can zoom in on your jurisdiction and look just at a certain state or just at a certain city. And then at the top, we've also given you sort of a quick status of what proportion of sites are in each, this is percent total change. So trend category, right? If they're blue, then the concentrations are going down over the past 2 weeks. If it's yellow, it's stable. If it's orange or red, it's going up. And we have to do these higher order metrics like percent change and relative level or percentiles because we're using multiple laboratories and we don't have a single standard method. In order to make the data as comparable as it can be, we look at these change and level metrics as opposed to absolute concentration. because that's not comparable across these different methods. Next slide. So you can look at this sort of, and just there's 4 graphics on here. Go ahead and bring those up. So that initial decipher page that you land on is going to be a quick snapshot of, where are we? Where is our jurisdiction? But you can also do data exploration and decipher. So the data at a glance that we just looked at, you can zoom into any site and see all of their data in detail. So that's what's on the top right. And so what you're seeing here, that black line and the black dots are wastewater data. So the dots are the individual data points. The line is a 7-day rolling average. And so you can see what's going on in any given site. This is concentration data, normalized to population and flow. Since we're just looking at one site, that's valid. We can also bring in case data. So what's showing here in those gray bars is the case data just from that sewer shed. So it's not county or city, it's just the area serviced by that sewer shed. So you're really comparing apples to apples as much as you can. We can bring in other data sources. So what you're seeing there on the bottom left is bringing in vaccine coverage data. So you can look and see how wastewater data compares to vaccine coverage or variants or hospitalization, any of the other metrics that CDC follows for COVID. And then for as many sites as we can, we're also showing geographic boundaries. For us, most of our sewer sheds don't align with county, city, zip code, census tract. They align with no other boundaries that are common in public health. And so it's helpful to be able to actually visualize what area the data is representing. So we don't have this for every site, but we're trying to get it for as many as we can. Next slide. And go ahead and click one more time. So we also have variant data. This was added in 2022, and we show that 2 ways. So at the national level, you can look at the dominant variant at any given site. So what's the most common variant at our sites, and how do those compare across cities? I realize it's way too small to see here, but across the top, there's a ribbon that you can say, BA5 is the most common variant at 26% of sites or whatever. So you can get a good idea of what the national trends are for dominant variants. Similarly, you can zoom into any site and explore that. So what you're seeing here is the black line, again, is concentrations. The stars are where we have sequence data. And then the colored bar along the bottom is what the dominant variant was for each of those sequences. So what you're seeing here is the BA, I think this was BA4 and 5, coming in green and blue and replacing the earlier Omicron variants. So you can see all of those at any site. Next slide. Oh, and then you can see how that compares across sites. So this is just another way of looking at the total jurisdiction. So where that little gray diamond is, that's the site that you're looking at in detail here in the middle. And then you can see how the trends there compare to all of the sites from that jurisdiction. So you can see it's a little ahead of the ones that are still showing that earlier Omicron green variant. Next slide. Also in September of 22, we implemented mpox surveillance. And that was really interesting because we had to go back and reevaluate how we're going to display this data because it was a new pathogen. It was going to behave differently. We knew the same types of visualizations were not going to work. And I apologize, this is really washed out on my screen. Hopefully you guys can see it. And so instead of looking at concentrations, which we didn't know whether or not concentrations in wastewater would correlate with case number, we decided to look at frequency of detection because it's a very rare infection in the US. And so frequency of detection is one more sensitive. And it allowed us to, continue watching concentrations to see if that's meaningful. So what you see here is a map with all of our sites where we have mpox data. Blue means that we haven't detected anything in the past 4 weeks. Yellow is a site where we have inconsistent detections over the last 4 weeks. And then red, which we don't have any right now, are consistent detections over the last 4 weeks. You can explore any site in more detail. So up at the top is a heat map of detections from a jurisdiction. And so hopefully you can see there's little blue bars, which are all of the places where we have samples. If they're blue, then nothing was detected. If they're red, then we did have a detection. And so you can see these are all of the jurisdictions that are testing for MPOX. In this case, it's a city. And so you can see that we did have some circulation going on in that city earlier this summer, and that's reflected in the wastewater data. You can also look at concentration data. So that's the graph on the bottom. We do share that with our health department partners if they want to look at it. Right now, we're not using that for any interpretation because, again, we don't know if it's meaningful for trends. Next slide. So the biggest challenge has been, how do we make this data available to the public? One of the things that's been really exciting is to see how much the public values wastewater data, but getting the information to them in a way that is interpretable has been very hard. And we have 3 public data sources right now. So COVID data tracker, wastewater surveillance, which is our trend and level information. There's a second page on COVID data tracker for variant surveillance. And then we have a separate page that shares the MPOX data. What I want to talk to you about today is that first wastewater surveillance metric. Next slide. So when we first attempted COVID data tracker, we put up a map with sampling locations shown as a point. We had a summary table because for it's called 508 compliance in the US. Basically accessibility compliance, we have to have it as text as well. So we had a graph plus a map, and then all of the data can be downloadable as well. So everything's public. And what we found was that no one understood this metric. So this is relative level. So is your concentration high or is it low? And what we got was that no one understood it. I mean, is it high, but is it going up? Is it high, but is it going down? Like, they wanted more information than what we were providing. So we went back to the drawing board. Next slide. And we really thought about very clearly, what are these 3 things? Who is the audience? And for CDC, it was very clear that that audience is the lay public. So it is not public health users. It is not those government officials. It's not academic partners. It is the public that is using this data to make decisions about how to keep themselves and their families safe. What's the message? And I'll come back to this because it's changing a little bit. At the time, we wanted them to be able to understand what's COVID data and wastewater looking like in their communities and others, although that's changing. And then how do we leverage CDC resources to support this? Next slide. So when we decided to update COVID data tracker, we made a few very specific changes. So the first is that we added other metrics, although I'm not showing them here. So in addition to looking at level, so is your RNA level high or low, we also provided trends. So is it going up or is it going down? But these are on 2 separate maps. So you can look at one map that shows you if your level, where are you now? Are you high or low? And one map that shows you where you're going. Are you going up or are you going down? We also added this visual that you're seeing here on the right. So if you click on any individual dot or location on COVID data tracker, it brings up this pop-up graphic that shows you the trend over time. And I think if you click on this, it's going to bring up some red boxes around these. Yeah, and 2 more. A really key thing here is that we did not put units on the axis. So remember that I said that we have different labs doing different tests. And so if you're measuring 100,000 genome copies in jurisdiction A, that doesn't equal the same level of infection as 100,000 copies in jurisdiction B. And we knew if we gave people a number, they would like link onto that number. And so the solution was, we're just not going to provide a number. We're going to show you the trends, but we're not going to give you numbers that we know are misleading. And then next click. The other thing we added was this new site, because one of the questions we were getting a lot of is, why isn't my community participating? And in reality, it was that your community is participating, but we don't have enough historical data yet to plot it. And so we added this new site marker so that people would know, like, it's coming. We're just waiting for more data. You also may have noticed some gray dots on these, so that's no recent data. So we continue to plot them if their data is old. So if we don't have anything in the last 2 weeks for COVID or the last 4 weeks for mpox, we gray it out because we don't want people acting on old information. So your community is still participating. We just don't have the most recent data. Next slide. We also decided to use interactivity and filters to help us highlight nuance of data. So particularly for our levels, the level of COVID, your current level is dependent on compared to the historical level for that site. And the Omicron surge in late 2021 really had a huge impact on how those relative levels worked. And so by default, we cut everything off after the Omicron surge. But if you want to see that historical data, you can bring it up and see what that looks like. So hopefully, making people pay attention a little bit when they click on that extra link. Next slide. So as I said, things are changing now. And previously, when we built COVID data tracker and this update that I just explained, people really wanted to be able to explore COVID data, and they wanted to be able to see all of it, and the users were really engaged. What we're hearing now is that people are kind of over that. What they want now is they just want to be able to click on it and say, in my community, is it getting better or is it getting worse? And so what we're working on now is an even more simplified, streamlined graphic where you put in your county or your zip code, and it brings up just a very simple graphic, like a single bar and arrow that says you're high and getting higher, or it's low and getting higher. Super quick snapshot to quickly convey, is it getting better or is it getting worse? This is not, again, appropriate for health officials. It's not where our public health implementers should be going, but it is what we are hearing that the public wants. So I just want to, I know we're at time, but I want to spend a couple of minutes talking about beyond COVID. Next slide. So let's skip this. Next slide. So as we're thinking about expanding, it is really kind of amazing how many different infections you can detect through wastewater. And so the question becomes, how do we prioritize our effort for wastewater surveillance? We can't look for everything. So how do we look for the most meaningful things? And these are the questions that we think about before we even start doing any kind of analysis of a particular pathogen in wastewater. So the first is, are there meaningful public health actions at the community level? Is messaging effective? Is there a vaccine that we can encourage people to take? Is there a message to physicians that would be useful, like for antimicrobial resistance? If the answer to all of those is no, there's not really anything at the public level, it may not be worth doing wastewater surveillance. It might not give you actionable data. The second is, of course, is virus shed into wastewater? So that's not just a yes/no question. If the answer is yes, then you ideally would like to know, what's the magnitude? What's the concentration of pathogen that comes from any one infected person? How long does an infected person shed? And is what's detected in wastewater infectious? Our utility partners really want to know the answer to that question. Of course, laboratory folks do too, because they're getting exposed to this. We often don't have all of that data, but our goal is, as soon as we start thinking about a pathogen for wastewater surveillance, we want to start pushing on getting all of that data. The third question is, can our assays that we use in the clinic be adapted for wastewater? So it's very rare that we're going to have wastewater ready assays for a pathogen ready to go. So we're usually going from our clinical assays and seeing, can the recovery methods that we use to process wastewater pull down this new pathogen and recover it and enable good quantification? And more importantly, is this assay detecting what we think it is in wastewater, or are we getting false positives in this very messy, dirty sample? And then finally, how are the cases distributed? So are there enough cases occurring in any one sewer shed that we're likely to detect them? And what's the case ascertainment rate and timing? So once people are infected, how long is it before they're usually diagnosed in the clinic and could be detected through clinical surveillance? And how many people do we think we're catching that way? So for something like antimicrobial resistance, we know that most people that are carrying antimicrobial resistance are not ever going to get diagnosed because they're healthy and they're not going to be tested for that. And if they are, it could be quite a long time that they've been carrying. So wastewater surveillance can help us with both of those, getting information on the full population quicker. Next slide. So as we work through the first version of sort of what should be our next targets, this is how we're expanding news to look at other core surveillance targets. So we have normalization and process controls. Pepper mild mottle virus and crassphage are two different viruses that are unique to human stool. And so they serve as good markers to standardize for human fecal input versus all of the other things that can be in wastewater. Bovine coronavirus is our process control. So we spike that into a sample at the beginning and then measure the recovery to know how well our assays are working. And then for our surveillance targets, we have a panel of antimicrobial resistance genes. These are the antibiotic resistance genes that have been deemed they're called antibiotic resistance threats by CDC. So most concerning for public health, the ones that we really want to put effort into protecting their utility in the clinic. So we're looking at those. For our pathogen targets, we have a respiratory panel. So in addition to SARS-CoV-2, we'll be looking at influenza A and B and respiratory syncytial virus, or RSV. We have a small foodborne panel, adenovirus 4041, Shiga toxin producing E. coli, Campylobacter, and norovirus. And then we have an emerging infections panel as well. So still continuing with Mpox and adding the fungal pathogen Candida auris as well. These are all in development now, and we expect to implement them through those centers of excellence in early 2024. And then we'll be developing new visualizations for all of these. So we'll have to go through this process again for each one of these targets to make sure that we're visualizing them in a way that is meaningful to the pathogen and useful for public health. Building that dashboard, both internal for Decipher and external for the public. And then our goal is to roll this out to the full system by August of 2024. So on a short time frame for that. Next slide. I'll just say here that we are moving towards a single test type. So we now have really good data that digital PCR works best for wastewater surveillance. So we're moving the system that way, but it's probably going to be at least 3 years before we get the full system switched over. Next slide. And then last, I just want to touch on some continued challenges, not just for news development, but for wastewater surveillance overall. The metrics are really challenging. What people really want to know is how many cases are in my community. That is a number that people are used to thinking about. Right now, we don't have models that can do that with any accuracy. They just have too much variability to provide useful numbers. But we're hoping we can get to that for at least some of our pathogens. We're continuing to improve methods and streamlining workflow. There are still questions about the impact of vaccination and different variants on wastewater surveillance. We're not seeing huge changes based on vaccination or variants, but we do want to stay mindful that those things can change the way an individual sheds the pathogen into wastewater. And so we need to stay attuned to those as broad trends and variants in vaccination change. And then last, I want to touch on ethical transparency. I have to give Canada huge credit. Public Health Canada was the first out of the gate with an ethical framework for wastewater surveillance that we still use as our touch point. But it's definitely something that we need to keep, in eyesight as we're continuing to develop wastewater surveillance for other targets. Every time we discover a new use or think about a new target, it raises new ethical issues that likely have not been discussed before. And so continuing discussion of ethics is going to have to be really front of mind for all of us that are doing this work. Next slide. And with that, I would love to take questions. You can find us at cdc.gov/news. And if you want to reach the news team, you can reach us at nwss@cdc.gov.
Thanks so much, Dr. Kirby. That was a really fantastic presentation. We have quite a few questions from different people who both on the panel or on the who are on the call now, but who also sent questions ahead of time. So we're just going to start. I'm going to start with some of the questions that people sent ahead of time. Quite a few people had questions about public health interpretation of data for the public. And some people followed them up in the chat, also asking how you are able to have for example, a figure with no units. Are you getting any questions from the public about that? So any additional comments on the process you went through to provide a product that was easily interpretable by the public would be much appreciated.
Yeah, I mean, the figure with no units, it hurts all of our scientists' hearts to put up a figure with no units, I will admit. But it's something that CDC broadly went to for the COVID response. And so a lot of our most public-friendly visuals have become more focused on trends and less on numbers, because unless you have a really good grasp of the underlying context, numbers can be misleading and not that helpful. Really, it's become, is it getting worse or is it getting better? And trends is really what you're asking about there. And so we've actually had very good response to that. I mean, we do get people asking for the numbers, and they can get to them. If you really want them, you can download the data, and the numbers behind those visuals are available. But I think really, just having that trend line has been really useful.
Okay, thanks so much. We have quite a few questions in the Q&A, so I'm just going to go through a few of them. Someone's asked, can you comment on the relative advantages and disadvantages of normalizing COVID wastewater data using a fecal strength indicator and normalizing using flow and population?
Yeah, so I think from a purely theoretical approach, it makes all the sense in the world that a microbial, well, we use microbial, it doesn't have to be, fecal strength indicator makes sense. And so that's why we have those microbial indicators of pepper, mild monovirus, and crassphage in there. In reality, what we have seen is that when we normalize, and in Decipher, you can choose either normalization approach, either flow pop or fecal markers. When we change to fecal markers, it actually makes the data noisier, and it reduces the correlation with clinical data. And so I think what that's telling us is that we just don't understand those fecal markers well enough. There's some other thing that's impacting those. We haven't totally given up, which is why we still have them in our panel. We think they're still worth exploring, but for use right now, flow pop seems to work much better, and it's an easier number to get.
Okay, thanks. Another question, which I was intrigued by as well, which is for the mpox data. How do you define an intermittent detect versus consistent detect?
So an intermittent detect is, well, actually, let me start with consistent. It's easier there. Consistent detect is more than 80% of samples collected over the past 4 weeks, with at least one of the being positive, with at least one of the positives being within the last 2 weeks. Intermittent detect is between 20 and 80% of samples within the last 4 weeks being positive, and then less than 20% is considered a non-detect.
Thanks. I'm guessing it took some time to come up with those guidelines. But
it did, yeah. We initially didn't have the 2-week rule in there, so we were just looking at like consistent was 80% in the past 4 weeks. And what we found was that everything became consistent and then stayed that way for a really long time. Like it took a long time for it to come back down to inconsistent. And so we had to add that 2-week qualifier in there to make it more responsive to a decrease as well.
Okay, we have another question, which is actually close to my heart as well, which is how often will the CDC be evaluating these programs to ensure they're still relevant with respect to public health actions?
Yeah, I love that question. So we have a internal advisory committee that's made up of subject matter experts from across the agency. So someone representing all of those pathogens that we're looking at in the next year, as well as other programs that have interest, hepatitis, opioids, things like that. That group meets twice a year, and one of their primary charges is to review the panel and make sure that we are still using our resources to address the most meaningful questions, and that our assays are still appropriate. There hasn't been, a change in the molecular epidemiology that would warrant a change in our assay for a target. And they will also be the ones helping us to consider new targets for inclusion. So annually, we'll be reviewing this.
Oh, okay, that's impressive. Annually. There's been quite a few questions about poliovirus detection in wastewater for obvious reasons. People want to know if it will be continuing. And also, is there consideration for traditionally reportable pathogens and treating detections in wastewater differently? So some sites apparently have expressed some reluctance to test for some of these. So I think it's more of a question overall about what the future of poliovirus wastewater detection is in the US.
Yeah, so right now we are only using polio wastewater testing to test around an outbreak, and an outbreak is defined as a clinical detection. So not necessarily a case, even if they're asymptomatic, but a clinical detection of poliovirus. We would then have wastewater surveillance in that community, surrounding communities, and communities that we know have been connected to that community through past outbreaks. So a good example was this, outbreak in New York in the past year. We knew that there have been connections to other communities in other states through prior outbreaks. And so we added wastewater surveillance in those communities as well. But we're not doing widespread wastewater surveillance there. They use a different approach for polio. So they do it through culture as well as PCR-based testing. And so it's a different level of lab capacity that's needed. And with the polio eradication effort, we don't have nearly as many laboratories that are approved to do polio work. And so it's really, it's finding the right line between implementation of wastewater surveillance and continued eradication and control efforts. So outbreak response has been the compromise there.
Okay, thanks. The questions keep on rolling in. A number of people have also asked about the use of wastewater surveillance for non-infectious agents, and in particular for opioid use in the population. Is that something that is being explored?
Yeah, this is something that we're looking at very closely. I think the real question there is, I heard one of my colleagues in opioids put it, the response is dependent on the intent of use, right? If you're using it because your doctor prescribed it for, chronic pain, we're not going to respond to that. If it is a, non-prescription or illicit use, that does fall under the kind of response that would warrant or kind of detect that would warrant public health response. But we can't distinguish those in wastewater. And so we are looking to do some evaluation studies to see if there's ways that we can look at wastewater data that will allow us to tease out some of those different trends. But right now we're at the evaluation phase for that. And I'll also note there's a significant ethical concern there as well about whether or not law enforcement would use this information for increased policing or something that we really, would rather public health data not be used for.
Yeah, the ethical consideration is very significant for the opioids surveillance, and it was great to hear that you are using the PHAC tool as well for ethical considerations. So I'm just looking through a few more of the questions. There was another question about interpreting data from jurisdictions using vastly different methods, so solids versus liquids, et cetera. And I think you spoke a bit to this earlier. Is a lot of people do, for better or for worse, compare between jurisdictions. So what kind of, how did your team address those questions?
Yeah, so the way we decided to deal with that is we collect a lot of quality assurance and quality control data around any given data point. So you're not just giving us concentration data, we're also getting the results of all of your quality control measures, your negative control, your positive control, your recovery efficiency for every assay, standard curves where they're applicable, and all of them, and also what method you're using. So that's all captured in the data. And so if we need to, we can go in and ask those kinds of comparisons, or how is, solids-based methods comparing to liquid or, whole raw wastewater? How are those comparing? Are we seeing, artifactual data from a certain lab or a certain method? We can ask all of that in our data. And if we need to, add additional normalizations and standardizations that are methods-based. We have not had to do that. We found that the trend metric and the percentile metric, because they are benchmarked to data from that site, that has enabled us to have comparable data, even with a lot of different methods. But I will say it has been useful to track down, like occasionally we'll have things like, a reagent goes off or there's a contamination event. Being able to look at all of the data from a certain location has been really helpful for tracking down those kinds of more typical laboratory data issues.
Okay, I think we only have time for one more question. So I'm just looking in the chat. Is there a rationale for the 7-day rolling average? Have you considered shorter time intervals?
So we do a 7-day rolling average because we have, for most of our sites, we're only getting 2 samples per week and they don't come in on the same day. So different laboratories and different utilities have different sampling and testing cadences. So 7 days gives us high confidence that every site will have 2 data points in that. If we go any shorter, we risk it only being 1 data point per site.
Yeah, I think that's been an issue for many of us as well. Okay, in Canada. Okay, I think we have time for one more question. I lied. There was a question about TB monitoring and TB antimicrobial resistance in wastewater. Mm-hmm. Are you able to speak to that? Is it particularly challenging, for example, to look for TB?
I mean, we would love to do that. So no one on our team is a TB expert. We've been doing some initial discussions with some of the tuberculosis experts on, what the possibility is there. I think it's something that we probably will pursue in the next iteration or 2 of the news panel. But right now it's still really early days. And I think for me, the question is really around latent infections. Ideally, we would love to see that this would help us get a better idea of, trends in latent infections. But I don't know if we have good data on fecal shedding and latent infections. So still a lot more research to do across, sort of the full clinical course of TB, which is challenging.
Certainly is. And yeah, the latency is a big problem because there's definitely a lot of latent infections out there. But we're really more interested in the tracking the active infections. So I think that's it in terms of time for questions. So I'm going to turn it over again, I believe, to Wendy to wrap it up.
I think it's Nicola.
Thanks very much, Rebecca. And thank you very much, Amy. That was just a fantastic overview. So many things that we have talked about in our SSGs, but also some things that we haven't touched on yet. Prioritization of targets, I think, is a very live discussion, both provincially and locally. Interesting to hear about some of the challenges, how many people are infected, that you think that you may be able to make some progress in that area, and in terms of the impact of vaccination and variants also in the data that you're collecting. I was intrigued, but we don't have time to explore it further, about the use of interactivity on things that you think are particularly important for people to register. So maybe we'll be able to talk about that at some point. And also, this whole question of focusing on trends versus absolute numbers or units. I think everybody on the line will agree that that's probably the way to go, and that's how we've been doing it as well. So a lot of similarity and some things that I think you're ahead of, and that we'll be following you very closely. So I did want to thank you very much about just taking the time to take us through the news program, both what you've been doing and what you're planning to do, and also, of course, to highlight our Blue Cities Conference, where we're going to be talking about the future of wastewater surveillance and the future sustainability of wastewater surveillance in Canada, because a lot of the relationships that were formed very quickly at the beginning of the pandemic with researchers and labs and public health units, some of those are not sustainable in the long run. So we have this fantastic group of public health officials, our very own Margaret Howard-Brockman moderating. Dr. Guillaume Poliquin is the VP of the NML, National Microbiology Lab, Dr. Bonnie Henry, Provincial Health Officer from BC, and Dr. Thomas Piggott, the MOH for Peterborough Public Health. We'll all be talking about different aspects and at different levels of government of the sustainability of wastewater surveillance. So I do encourage people to look at www.bluecities.ca to look at the agenda, the program, and to register. And I also just want to take a moment to talk about the evaluation. We would really appreciate it if you would complete the evaluation. I think there's a slide coming up on that. There we go. So you just have to use this link through the in the chat or in the QR code. This will help us enormously to evaluate this particular webinar and just resources and information that we provide to you in the future. So I do want to wrap up just to say thank you to everybody who joined the call. Hope that you found it as informative as we did. I want to thank Margaret for being the moderator, or for being the introducing the moderator, and Wendy Pons for serving as a moderator, and Rebecca Stewart for mediating and facilitating the question and answer period. And most of all, Dr. Amy Kirby, thank you so much for joining us today.
Thank you for the invitation. It was great.